Hey everybody, welcome to the lecture on Is Heaven the New Lemons? Objectives, we're going to look at specifically assessment tools for airway management. We're going to look at applying a retrospective review and look at data that was designed to look at a new airway tool. We're going to demonstrate and validate what's called the Heaven Assessment Tool and integrate that Heaven Assessment Tool into an RSI checklist and really just talk about the evidence surrounding this new way of looking at advanced airway management, really focusing on the emergent airway. Everybody should know LEMONS. LEMONS has been around for quite some time, obviously validated in the early 2000s between June 2002 and September 2003. And it really was a study in Scotland designed for ED airway assessment, and a lot of times also looked at and used in the anesthesia world for that preoperative assessment. But does it really give us the information we need when we look at an emergent airway? LEMONS, as we all have learned over the years, stands for look. We're going to evaluate that 3-3-2. We're going to look at a Malampati classification. We're going to look for any obstructions. We're going to identify and assess for any neck mobility and obviously look at saturation. When we look at the evidence-based practice surrounding that paper that was published in 2005, really the look and evaluation of lemon in that ED patient was shown in this example of giving the physician the ability to reduce the likelihood of having a poor encounter or a problem intubation, right? Gives us some added information where we can make better decisions with our patients. But does that really resonate for that rural emergent airway? And that's really what we want to talk about in this case. So let's break down LEMONS really from a finite standpoint. The first thing we're going to do is we're going to look externally. Do we have anything obstructing the airway? As you can see in this example, obviously you have a large branch moving through the mouth oropharynx into the back or outside the left side of the jaw. So are we going to be able to manage this patient from an airway standpoint? Obviously, in multiple ways we can transport these patients. We can transport these by ground or by air. And really, if I were to land on scene on a scene flight, I definitely would not go by air with this patient in most cases. I think it would be much safer to go by ground with this type of patient. And I think it's just based on could we manage the airway if this patient started having some problems in a small enclosed environment like a helicopter. And I think we would have a much easier time to sit him up in a position where he could clear his airway in an ambulance than we would a helicopter situation. The next thing we're going to do is we're going to evaluate the 3-3-2 rule. And that 3-3-2 rule is going to be looking at really mouth opening. Can we put 3 fingers in the mouth from our end of our chin or back to that hyoid bone? Do we have a 3-finger depth? And then down from the bottom of the jaw down to the thyroid notch, do we have at least 2 fingers? In my experience, this doesn't give me a lot of information. Obviously, I want to know if I can open the patient's mouth, but does it really give you the information needed to make a decision on if this airway is going to be difficult or not? And in my experience, some airways that I evaluate that appear to be, or I would assume to be difficult, have been very easy. And in contrast, ones I felt like would be easy were more difficult. So why would we use the patient's fingers and not our own? Well, obviously, we want to be safe. We also want to understand it's just like when you look at burned surface area and we're doing the rule of palms, you're supposed to use the patient's palm size. Right, our hands should be the size appropriate for that person or that patient's body. You have a guy, I've got pretty big hands, and I'm dealing with a woman. My fingers are going to be bigger than that patient's. and vice versa. So we want to make sure that we're using the appropriate gauge to assume hey, my patient can open their mouth to the position they need to where I can actually get a laryngoscope in the mouth. And obviously, for safety purposes, we don't want them to clamp down. We don't want them to bite us, etc. So really use caution, obviously, use common sense and make your determination. What about the Malampati classification? I see this misused all the time. We got to remember, and oftentimes we mischart this. This is something where we're just going through the charting program. We're checking boxes, and your patient is listed and documented as a GCS of 3, obtunded, unresponsive, but you document a Malampati score of 1. That's impossible, right? We got to make sure we understand Malampati. Patient has to be conscious, alert, oriented, able to sit up, open their mouth, and you're able to get a good assessment. Can I look all the way into the back of their throat? Can I see their uvula? No obstructions. Can they stick out their tongue? Right? Follow commands. And you could see from a picture A at the top left to really picture D, the big difference. Now, this is a great example of where I have used this on conscious patients. And A looked great. I've had patients that look like Ds, and Ds have been very, very easy in comparison. So again, I think the point that we're trying to make is LEMONS is good for certain situations. I'm not confident it is the perfect assessment tool for that emergent airway where we see these types of airways in the pre-hospital setting, whether you're ground EMS or in the HEMS industry. Obviously, ED physicians, mid-level, see emergent patients, and that's where we're going to talk about a new assessment tool. The next thing we're going to look at is the obstruction side. Do we have any obstructions that's going to impede your ability to, number one, assess the airway, to look inside the mouth, and ultimately to be able to oxygenate and ventilate? Those are the first 2 questions you always ask yourself before you perform rapid sequence intubation, before you induct somebody and make the decision to paralyze them. You need to be able to oxygenate and ventilate that patient. And so if you have obstructions, it could be secretions, or it could be based on trauma. Do they have a Lafort's 3 fracture? Do you have copious amounts of secretions, blood, vomit in the airway? Or do you have, as we saw in that previous picture, do we have some type of penetrating trauma to the oral pharynx or the face? Do we have a patient that has a gunshot wound to the face? So we just want to make sure we understand what we have, and then we're going to make a decision on how to proceed based on that assessment. What about neck mobility? Obviously, if we have a trauma patient and you have determined that this patient has a potential C-spine problem, we've seen a huge change in the last 5 years on C-spine clearance in the field, not boarding every patient. But really, in my experience, when you're taking a patient to a level 1 trauma center, there might be some hospitals out there that have moved away from this, but in my experience, they still want the patient boarded and collared. Not saying that is the right thing. I'm not saying that's the wrong thing. I think the evidence shows that hard collars are probably not the best thing for our patients. Ultimately, though, when we have a patient in the back of an ambulance or a helicopter, we have to make a decision on intubation. The thing we have to remember is first pass success is the key. Can we move the jaw? Can we move the neck? Obviously, not excessive movement, but we want to be able to have the ability to open the mouth, jaw thrust, things like that, to where we can actually open the airway and manage that airway. And oftentimes what we always teach is have somebody hold from an anterior position from the chest to the neck, remove the collar or open it up if you have a collar on, and give yourself the best first chance at that intubation success by doing just that. The last thing is saturation. The thing we have to understand about saturation, and I've talked about this in many other educational videos, is we have to be very, very careful. We have to understand that saturation is just an indication of hemoglobin's ultimate seats being filled by oxygen. And that can be altered for many reasons. But really, when we look at the big picture, do you understand a patient's shock state, their hemodynamic instability, their decompensation directly will affect your ability to assess an SpO2 that's accurate. And that's what's called SpO2 latency. It comes back to position, where that probe is located. And a lot of the research has come back to, hey, are we using the right equipment? A finger probe, we have seen, is not going to give you an instantaneous reflection of what that SpO2 truly is. You compare that to that Masimo ear sensor where it's placed on the earlobe. That's the core area, right? When we're in shock, all that core blood goes into that core area to our brain, our heart, our liver, etc. And so that is a very hyper-perfused location that's going to be pretty instantaneous and give you a true reflection. So understand SpO2 latency. Understand if your patient is cold, if they're older, if they're on medications that might blunt their compensation, you're definitely going to have an alteration in that SpO2. So make sure you have good pleth and change positions or locations if you don't feel like you can trust that number. So was this effective? When we look at this from an airway assessment standpoint, when it was studied though in the ED, when it was studied in the pre-hospital setting, it was noted that really the patient needs to be awake and cooperative, but the data did prove that this tool was effective in the emergent airway. So when we come back to the evidence-based practice side, let's look at another example of taking that initial study that was done in Scotland, and they reduced a portion of that assessment, and that is what's called the Leon assessment. When we think about the Leon assessment, really it is subtracting the Malampati classification. And so what did they find? Well, they found in conclusion that the modified Leon assessment is reliable as a predictor of a difficult intubation. It's applied in the aeromedical operations setting with a Leon score greater than 2. It showed it was significantly more likely to predict a failed airway when you contrast that to not using this assessment. So again, it's a good tool. It definitely gives us some ability. And I think when you look at anything like this, any assessment tool we have, for me, what it does is it makes me aware. It makes me slow down. It makes me evaluate the situation and not rush things. And that's why when we assess our patients and reassess our patients, it helps us reset our mind and reevaluate what's going on around us. Now let's get into really the meat of this lecture and this new topic, and that's what's called the Heaven criteria. Heaven criteria was a study done from a retrospective review of data, and we'll touch on that. It was done by Aeromedical Corporation and their clinical education team, led by Dave Olvera, Dan Davis, and Alan Wolf. And what they really wanted to evaluate was there a better way to really assess that emergent difficult airway. And I think that they really came up with an amazing acronym and assessment tool that we're going to talk about moving forward. When we evaluate Heaven criteria and we look at this study specifically, it was a retrospective study done by Air Methods using airway data from all the flights in the Air Methods community-based programs. And really, they were aware of the Difficult Airway book put out by Walls in 2008 that really said that the evidence-based guidelines for prediction of difficult airway using specifically video laryngoscopes may be challenging or even impossible to develop. And so really that was the thought process, as they had employed the CMAC laryngoscope devices. And really the training was focused on what is the best approach? Is it VL, video, or DL, what we'd used for years and years and years? And can we evaluate how our providers are managing these patients? What's the best way to reduce our first pass failure rate? And so the design really was focused on looking at all these data points, and there was over 200 data points that was evaluated constantly. So let's break down the Heaven criteria, and then we'll discuss the study and the design. Heaven criteria, as I said, is an amazing tool that I look at from two perspectives. If you look at the different levels of the Heaven criteria, you're going to notice that these are levels of resuscitation. There's some resuscitation reminders in here, and there's also some reminders and similarities to the LEMONS, really mnemonic. So we start off with hypoxemia. That is definitely an assessment type of thing. We want to evaluate, is our patient hypoxemic? We've learned it's better to slow down, evaluate your patient, oxygenate your patient using passive oxygenation techniques first, nasal cannula, maxed out, non-rebreather maxed out, have a BVM ready, have it waiting, have a PEEP valve applied, but we don't just automatically start bagging our patients. We want to use passive oxygenation, but we want to make sure our first passed attempt is going to be in that 93% or greater SpO2 range. Number 2, extremes of size. Is your patient a very large individual? They have a very large head, no neck. Is it going to be very difficult? Are they very anterior? So again, it makes you evaluate the situation, and then you can determine what the best approach is. It a VL approach or a DL approach? The next is anatomic disruption or obstructions. And so we saw the same level of assessment in LEMONS. Do they have any disruption to that oral nasal pharynx? Think about a shotgun blast to the face. Think about something protruding into the oral pharynx, not allowing you to open the jaw. It could be a burn patient that's significantly burned. Next level, number 4, is vomit, blood, or fluid in the airway. And notice they recommend either or, DL or VL. And that's where we come back to and really start pushing the SALAD technique. The SALAD technique is suction-assisted laryngeal airway decontamination. And that was invented and thought of by Dr. James DeCanto. And that's something we should do for every single airway that we place in or make the decision to place a laryngoscope in and an ET tube in. Is we want to make sure we suction first before we do anything else. We want to make sure we're suctioning, getting rid of all those secretions, whether it's a small amount of glottic secretions in the back of the airway. Anything like that can cause ventilator-associated pneumonia later on once that patient is at definitive care. And oftentimes in the pre-hospital setting, we just don't even worry about that. But that's a big, big factor in mortality. Next thing is exsanguination. Does your patient show signs of hemorrhage, blood loss? Remember, we can lose 80% of our volume in our pelvis alone. We can lose a couple liters in each femur. You may not see outwardly any hemorrhaging, but understand a trauma patient that is significantly hemorrhaging. They've got multi-systems trauma injuries. They could have significant blood loss in their chest, their abdomen, their pelvis. Their O2 carrying capacity is now depleted. They are not going to maintain an SpO2 very long in those apneic phases. So if we go all the way back up to the hypoxemia side, if you have any suspicion of exsanguination, and I would say every trauma patient should have that mindset. When we perform passive oxygenation, we get SpO2 greater than 93%. Take the non-rebreather off, but you always leave that nasal cannula on through the entire procedure. You never take it off. And that will really help you maintain an SpO2, because our stopping point in that intubation phase is if that SpO2 drops below 93%, that's when you stop and you regroup and you have to re-oxygenate your patient. Because remember, we want a first pass success, but we want first pass success without desaturation. I can't state that enough. Without desaturation, it's all right to stop and regroup. And that's where you work with a partner that's watching the monitor. Again, it comes back to, though, also your awareness of SpO2, hemodynamic stability. Can you trust the SpO2? Is the equipment you're using, does it give you a true reflection? Are you using that Masimo ear sensor that gives you a pretty instantaneous change versus maybe a standard finger probe? And lastly, neck mobility. I talked about neck mobility in LEMONS criteria about removing the collar, opening up the anterior part of it, holding anterior C-spine stabilization. Ultimately, though, we have to get first pass success. Now let's look at the data registry. When they started collecting this, they got up to initially 160 data points, which expanded to over 200. At the time of really putting out the data based on this retrospective review, there was 5,500 live intubations in this data set. And so that's huge. These are all flights within the Air Methods community-based system. The data was collected based on a post-flight debrief. And so let me just kind of tell you how this went. Within these programs, there was a software that was being used. You basically did a flight debrief, and based on the questions in that flight debrief, it would trigger a secondary type of form that you would have to fill out. So if you clicked, hey, this patient is an airway management patient and you performed RSI, it's going to ask you a secondary set of questions when you do your post-flight debrief. And so it asks you everything you would ever think of. And that's where these data set points come from. All that goes into a system. And so approximately 99.9% of intubations were collected. There was a weekly report that was sent to the education team where they could follow up on anything, they could ask questions, and management could take that data and add it to a large data set to evaluate. And guys, this is a great example of changing the practice real time. You're always looking at this data. You're evaluating what's working and what's not working. And you can see in real time things that should be changed. Or is this a training problem? Can we change our training approach based on some of these data points? So it's pretty neat when you have the ability to do that. The validation side really was the team recognized that really the prediction of difficult airway and resuscitation is vital for improved patient outcomes. And it comes down to understanding the laryngoscope that you're using. As I said, they were using a CMAC laryngoscope. And so it's about the view, it's about really positioning your patients, but really focusing on both direct and video. And what they did is they came up with what's called the crossover technique. The crossover technique is brilliant in my mind because when you think about evaluating first pass, second pass, the company you're working for has to evaluate what truly that is. A lot of places, it's if you place the blade in the mouth, that is a first pass attempt. It's not truly putting an ET tube in. You make an attempt with that laryngoscope, that's a first pass. So really what the crossover technique is you go in, let's say in a video manner, right? You're going to use your video as your first pass, but you immediately recognize you have so many secretions that's obstructing your camera view. You immediately bring your eyes down and now you have a direct view. And so you have only still done one attempt, but you've moved from video to DL based on what you're seeing. And again, it comes back to the Heaven criteria. Hopefully, based on your assessment using that tool, you've evaluated, hey, I probably have secretions. And that's where you would use the salad technique. But ultimately, what it does is it prevents us from having too many attempts. And vice versa. You determine, hey, I am identifying a hypoxic patient. They're not maintaining SpO2s like I'd like, even though we're really oxygenating them with passive oxygenation. I feel probably more comfortable with this patient to use a DL approach. I'm going to go direct, and you evaluate, hey, I'm going to do direct, and you get in there and you realize, hey, video is going to be better. You can simply move your eyes up to the camera, readjust your blade. So that's really the approach to the validation side, is understanding. It comes down to training on both direct and video applications. The study, really the retrospective study, was looked at in December 2014. All patients that received RSI for intubation. This program specifically, I would say nationwide, their guidelines really dictated that there was never any crash airway. So there was always a sedation drug, etomidate or ketamine, given prior to any paralytics. Complete data collection to include Heaven criteria, looking at that Cormack-Liane view and success of attempts. At the time of the study, there was 5,100 approximately patients received RSI attempts by the Air Methods flight crews. throughout the United States. 98% of them, 4,990, received paralytics as part of the RSI procedure. So even though the guideline dictated that, hey, crash airways, really kind of discouraging crash airways, doesn't take but a couple more seconds to draw up some ketamine or etomidate and administer that, still there was only 98% that received paralytics. And that comes back to what do you do for patients that are in cardiac arrest? So really the thought process within Air Methods at that time, I'm not aware right now what their approach is, was if that patient had a pulse, even though they were obtunded, maybe they didn't have a gag reflex that you could identify, you still performed full RSI. The only time you would not perform RSI would be a patient really in cardiac arrest. When we look at the analytic strategies, there was multiple. Number one, patients with Heaven criteria were compared to no Heaven criteria regarding the laryngoscope view. So again, DL versus VL. Number two, the relationship between the number of Heaven criteria and the laryngoscope view explored. And really what we're looking at from a view standpoint is the Cormack-Liane, which is 1, 2, 3, and 4. And number three, looking at specifically a multiple logistic regression using independent relationships between each the Heaven criteria and a likelihood of a difficult airway. Again, looking at Cormack-Liane 3 and 4 and a good view, or a Cormack-Liane 1 and 2. So this is a great picture here, guys, that really depicts what we all have been taught when we were using just our DL approach, standard laryngoscopes. We always try to focus on that view on the far left, that A view, that's Cormack-Liane 1. But if you've trained with a video laryngoscope, you know that it's very, very easy. You have a camera that's at the distal tip of that laryngoscope, and it is zooming in on your structures. And so even though you might see this perfect view on A with a video laryngoscope, what's happening is you're probably too close. The distal tip is right up against the cords. The camera sits a little bit off of that distal tip. And so when you go past that ET tube, you're unable to pass it. So what we really focus on is understanding that a little goes a long way. With a video laryngoscope, you want to just gently enter into the mouth, midline, right? We're not sweeping, we're just going straight down the midline and slowly lift. And a little goes a long way. And so really what we're looking for is this view right here. That is the most optimal view with a video laryngoscope using a VL view. So when we look at the data table here, some things to really point out is when you go all the way down to the innovation data, look at first pass success. I got that highlighted right here. DL was 85%. VL was 87%. When we look at first pass success without desaturation, which really is the gold standard, 76% with our DL, but 83% with our VL. Ultimately, the overall success was 94 with DL and 95 with VL. So very small difference there, but that is what we really want. We want a high success rate. And I can tell you that over the years of them looking at this data and training and looking at the data and training, they got their first pass success up into the 90s, 93, 94, 95 at some point. And so that is really, really amazing from that standpoint. That is equal to what you see with ED physicians in the ED that's innovating all the time. So it comes back to constantly evaluating the data. It takes a lot of time. It takes a team effort. It takes a really, really robust QI, CQI program to evaluate and look within your clinical team and evaluate and say, are we doing everything we can from the standpoint of training? Can we change anything? And so I think the success of this program really comes back to the team that was conducting this retrospective review and the ultimate implementation of any changes throughout the programs. So let's look at the results. As you can see here in this chart, the DL versus VL, we look at difficult airway percentage, and you have the elements of our Heaven criteria. Notice that patients that had hypoxemia, for example, more times than not, video laryngoscope application was used. Extremes of size, it was more of a DL approach. Anatomic disruptions was more of a DL approach. Vomit, blood in the airway was more of a DL approach. And you can go all the way across the sanguination, neck mobility. So why was that? Was it bias from the provider? Is that because we've always done it that way and they felt more comfortable? I think there could be parts of that. I think that when you saw the implementation of video laryngoscopes in the industry, there were a lot of naysayers. There were a lot of, right, we don't want change. We don't want to relearn something. And I definitely reflect on the first time I used a video laryngoscope, even the CMAC that replicates a normal, Macintosh blade or Miller blade, same exact feel in your hand. It still is completely different when you apply the whole VL side. So when we compare it to this chart, and now we actually are looking at the number of Heaven criteria applied. Again, when you look at this from, hey, we've always used a DL view, it was very hard to convince a lot of people to move to that whole VL approach. Notice that the amount of Heaven criteria directly dictated, hey, more times than not, the DL approach was the way they went. Was that because that's comfortable? Is that something that they're more confident in? If we expand on the results, they did a logistic regression analysis that really explored the difference between the airway view. So was it a difficult airway, Cormac-Leane 3 or 4, or was it a non-difficult airway, a 1 or 2? And really looking at direct laryngoscope application using either the individual Heaven criteria data points. So what is a logistic regression? Really in statistics, what that is a model for probability. And it looks at certain classes or events that exist in the study. It could be a pass-fail. It could be a win-loss. It could be alive or dead, right? Is the patient healthy or sick, etc. They looked at specifically age and gender and clinical category, right? Was it a trauma patient, a medical patient? What paralytic did the flight crew choose to do? Because they had the ability to choose between sucks, rock, or VEC. Where was the procedure done? Was it done in the back of an ambulance? Was it done in a hospital setting? Or was it done in flight? And then compared that with each of the Heaven criteria. So one of the interesting aspects of this data set was they were able to look at a lot of things after the initial null hypothesis was evaluated, right? You come up with that null hypothesis, you come up with really the clinical question of what the study's trying to answer, but really afterwards you have all these other data points and you can evaluate other things. You become curious or things come up in the CQI process. So one of the areas that I found very fascinating, it completely changed the way I approach airway management in the aeromedical environment, is we used to really try to get off scene quickly. We tried to move to the helicopter as quickly as possible, intubate in flight. And what this data set showed is there was a higher amount of patients that had a desaturation being intubated in flight than in a stationary environment like the back of an ambulance or in a hospital setting. And then the second area that they looked at that I thought was profound was, does the size of the helicopter, does the airframe predict if these patients have a more difficult time, right? The providers have a harder time. Patients may have a desaturation. And the thing that was amazing was the bigger airframes like the 145s, the BK-117s, the EC-135s, those were not the best helicopters intubated in. It was the smaller airframes like the A-Star, EC-130, those airframes like 407s that were better. And so there was a higher complication rate with the bigger aircraft. And so I think when you look at that, you have to ask, why is that? Is it a feeling that the crew is more lax? I don't know. But what it really showed was it's probably not the best option. You have a higher probability of having problems when that happens. So it comes down to really taking that mindset and understanding that we need to slow down. We want to reduce those desaturations. We want to make sure we resuscitate our patients prior to giving any sedation, any induction meds, any paralytics. And so if you stay an extra 10 minutes on scene, but you get a good definitive airway placed, first pass success, no desaturation, you fill the tank, right? Your patient is stable. That's much better than having a desaturation or a sentinel event or having a patient decline or arrest. And so I think we've learned a lot of great lessons from these data points. So we look at that regression model on direct laryngoscope application. The thing that I want you to notice in these next two slides is that we have two different data sets. We have what's called an odds ratio, and that odds ratio in research is always going to be an odds ratio with a confidence interval of at least 95%. That is the standard. And we also have in the column on the right the p-value. So the thing about an odds ratio, guys, is 95% confidence interval is always really what we're looking for. So what is an odds ratio? An odds ratio, guys, again, we want to make sure we understand that 95% confidence interval is the key. That's always going to be the standard. And really that ratio is looking at if the same population were sampled on numerous occasions and a confidence interval estimate was made on each occasion, the results and the intervals would contain the true population parameter in approximately 95% of the cases, assuming there was no bias. So if we look at the odds ratio from a range, let's say we have an odds ratio of 5.2 with a confidence interval, again, you have that range of 3.2 to 7.2, what it suggests is that 95% probability that the true odds ratio would be likely to lie in that range of 3.2 to 7.2, assuming again that there's no bias. And then we move on to the p-value. And most authors basically look at the p-value from a statistical strength. And anything statistically significant is going to be a p-value less than 0.05. But when you get into a statistically high significant p-value, that is going to be less than 0.001. And so that's where I want to lead us to is look at what we have. We actually have in the direct laryngoscope data set in comparison. In the direct area, really looking at it from the anatomic disruption, the vomit, blood, fluid in the airway, it was significantly better to use a direct view in comparison to the other approaches. But I also want you to understand that the other parameters, hypoxemia, extremes of size, sanguination, neck mobility, all those p-values are less than 0.05. And so that is still significant. It's just not highly significant like you're seeing the p-value of less than 0.001. When we now compare that to that video view, I want you to notice that we have three areas that were statistically highly significant. We have hypoxemia, extremes of size, and vomit, blood in the airway, with all of them showing a p-value of less than 0.01. Remember, though, when we saw that previous slide and we looked at the DL, the vomit, blood, and fluid in the airway also was statistically significant in that high area of a p-value of less than 0.01 as well. So what that shows is really it's going to be based on the provider. Both of them are significant in when evaluating the Heaven criteria in first pass success using either video or DL views. But as I said, sanguination, neck mobility, all of those other ones had a p-value less than 0.05. And so it is still significant. And when you look at the very bottom line here that I have highlighted, just like we saw with the direct view, using all the Heaven criteria, combining all that data together, it was significant. So really what the data says is it's not really based on DL versus VL. There might be reasons why you go one over the other. As I talked about the whole crossover technique, not every patient is the same. We know that. And so you have to use critical thinking. You have to assess your patient. And really it comes down to assessing for resuscitative measures. If they're hypoxic, then you treat the hypoxia. You don't intubate till you have SpO2 greater than 93%. If your patient is, sanguinating and you understand, hey, I'm hemodynamically unstable, I need to make sure I get some volume on board. I need to maybe use a push dose pressor. I need to make sure, hey, maybe we should start some blood products. I've got a neck mobility issue because I have a C-collar in place. Let's remove the front part of that C-collar. Let's make sure we have full access to the neck. It's those types of things that really are going to make the difference. And what I always say in airway management is really be proactive, not reactive. Be ahead of the game as much as you can. And that's what, for me, the Heaven criteria is. It's a resuscitative tool to make sure that we're checking the boxes before we make a mistake. So when we look at specifically this section and this part of the results, really what it just says is that in the direct laryngoscope application, it all comes down to axis. It comes down to making sure your patient is positioned in the right way, head elevated 30 degrees at least, sniffing position. If you were to draw a line from their earlobes to their xiphoid, you have an obstructed view. So it's all about positioning and making sure you're in the right position before you move forward with that intubation attempt. And so really the differential was not observed with Heaven criteria, reflecting that it's about speed in those patients. It's about, the hypoxemia, sanguination, extremes of size. It's about how quickly you perform that and how successfully you are really on that first pass attempt. And the rate of desaturation can be predicted by both, obviously, pulse oximetry and hemoglobin concentrations. If you're in an environment that you have that data from a lab standpoint, that's great. But you have to assume a hemorrhaging patient has a drop in hemoglobin O2 stores. And that's going to affect your time for safe apnea and really cause you to have to evaluate direct versus video equally. And so again, it comes back to looking at Heaven criteria specifically and going through those different aspects. What are some limitations to this study? Well, could there be reporting bias? Absolutely, right? This was on the honor system. Obviously, every flight had to be evaluated. The questions had to be asked. This was really, really rigorously followed and watched. And so, it wasn't that the data wasn't inputted, but was the data inputted carefully? Was it inputted in a way that there was no bias? And you can never say never. So definitely something to consider. Influences of multiple co-founders could not be determined. Provider type, experience, really the patient type, physiologic norms, and then really the airway characteristics for each patient. So this was across, all demographics of patients. To expand on the limitations, one of the things they really took into consideration was, hey, we might have that bias. We might have issues with data entry, etc. But hey, let's make sure that we have protocols that are expansive. They're the same. Uniformity was a big key. And make sure that everybody understands Heaven, that they understand how to assess a patient with Heaven criteria. Making sure that they understand the different VL versus DL views and when to apply them. But ultimately to teach how to manage these patients. And that was one of the thought processes to offset the influence regarding those factors. And lastly, what they did to really enforce this even further is they came up with a RSI checklist that had an expansive checklist on the left, and on the other side of that checklist, just hung on your badge, was the Heaven criteria. And what we were really training our flight crews to do was to hand their badge to another provider. Don't use you or your flight crew. Use another provider on scene. It could be a nurse in the hospital. It could be a doctor in the hospital. It could be in the back of an ambulance, EMT, paramedic, from the ground agency, and have them go through each one of these to make sure as a double check that we hit on every one of these things. And so it was a great tool for training, great tool to build relationships with other providers, other agencies, and hospitals. And so is this the standard of care? Well, absolutely. This really has made it to publications all over the world. It is now part of the PHTLS 9th edition. NAEMSP Airway Doctrine is using it. Pre-hospital settings in emergent airways are using this all over the world. Hospitals now are using this in the emergent airway. And this was presented at the World Airway Management meeting in Europe as well, and it got rave reviews. So definitely, if you have any questions on this, don't hesitate to reach out. And in summary, guys, strong associations between difficult laryngoscope views, again, Cormack-Liane 3 and 4, and then applying the Heaven criteria to help predict for resuscitation prior to RSI, and then using that to then make a determination, hey, is it better for me to go DL first or VL first? I like to say that it's a better resuscitative tool or indicator than anything else. And understanding how to use your specific video laryngoscope, because not everybody has a CMAC, right? You might have a McGrath, you might have a King Vision. There's lots of different ways to do it, or a GlideScope. You have to train on that specific device. But the data points really support the use of Heaven criteria as a difficult airway tool or predictor for out of OR intubation. And I think it's much better than the LEMONS mnemonic. If you have any questions, guys, please email me, eric.bauer@flightregent.com. I would love to answer them, and I can definitely get you in touch with the authors as well. I'll talk to you soon.